everybody can hear me. My name is Dr. Peter Noel. I'm a board-certified veterinary radiologist. I stare at a screen all day. I got super bored, not bored. I was looking for a creative outlet, so I thought I would chat with y'all, figure out how to improve your diagnostic imaging skills, have some fun. This is the 15th episode. Dr. Holmes is here. Dr. Elaine Holmes, colleague of mine. I guess you're all colleagues. She knows me a little bit better. I think this is her first one. I may or may not be pilfering the neighbor's internet, and so if the camera drops out, we'll be back online shortly. Here's what we're going to do. For those of you that haven't joined, best thing to do is crank up the brightness on your screen. Ideally, drop the lights. The best thing, this is not so much about knowledge as it is about skill. And so in order to practice the skill of identifying diseases and potentially trying to formulate an opinion about the diagnosis, the most benefit you can derive is to stick your neck out and try to actually write down what you think the diagnosis is. You can drop that in the comments, or you can just write that down on a piece of paper. If you say something in the comments and you're ashamed or embarrassed, we can always just go ahead and edit that out before it gets pushed to YouTube. Light editing from my cousin Chris. So without further ado, let's jam. First case, let me see. I've talked about these guys before. There's a website called imaios.com. It's kind of amazing. You go to vet anatomy, anything you want. Osteology, rads, oh boy. I mean, too much, right? So you can toggle on and off. This is a total must. I use this. I don't use it for rads as much as I do cross-sectional, but everything. You name it, they got it. This thing is great. Pretty inexpensive. I think it's like $80 for the year. I use it daily. I would use it. IMAIOS. No, they're not a sponsor. When you have 12 people joining you live, you don't get a sponsor. So I'm going to set a timer. Okay, so we got 4 views of the abdomen. This is a male dog. He's probably 4 or 5, and he's vomiting. Okay, so we got one. We got a right lateral, left lateral VD, and a VD. Okay, here we go. Okay, so Lucy's going for it. Lucy's a longtime listener and contributor, and almost everything that she says is correct. Okay, so now I'm going to tell you what I see. Okay, so caudal, and this is just the method in which I do it, right? Caudal thorax is normal. The liver is rounded. That shouldn't be, even though the gastric axis is parallel and everybody, that's great. And but this is too round. Could that be the gallbladder? It's possible. A physiologic gallbladder distension, it's possible, but you at least have to comment that that's not normal. There's also this ventrally convex bulge that looks like it sort of butts up to the splenic tail, so you could wax poetic about what that is. I doubt it's an intestinal loop that's superimposed over that area. The colon has a decent amount of formed feces in it, and a lot of these mineral fragments, rocks, colon. The rectum has rocks, colon pops around here, right? So nice set of formed feces. The stomach, small amount of gas. This is not black. It's sort of gray because there's a little bit of fluid and not just gas. So I would say the stomach, which is right here, is mildly distended with a combination of fluid and gas and small rocks. Even though these rocks are in the pyloric area in the left lateral view, I don't really think that should be that noteworthy. Most of it is full of gas. Over here, it's full of gas. Yes, those are in there. But I think the reason that I wanted to show you this is because the dog, this is like Mother Nature's BIPs. Remember barium impregnated polyethylene spheres? So sometimes you give these dogs these barium impregnated spheres and you'd see where they'd go. The fact that a large portion of these are in the colon, even though you've got some that are in the stomach and some that are sort of scattered randomly throughout the small intestine, the fact that the majority of them have, or a large portion of them made it to the colon and the rectum, and even some of the large one, all bets are off. You should not be cutting this dog. You should just chill, wait a little bit, maybe 12 hours supportive care. I would 12 hours supportive care, fast it, so there's not this complication about what's in the stomach, because I would love to see the stomach be almost completely empty. These be gone, these be gone, those be gone, just be gone. So GI form material, potentially some hepatomegaly, maybe a liver, a splenic nodule. What else? Everybody always loves, you got to comment about the hips. Hip joints are normal. Repeat X-ray. Okay, I thought this was supposed to be a hard one, but apparently it's not. So, all right, fine. Here we go. Let's turn up the heat. Let's see, 569,351. Okay, 3 views of the abdomen. The younger cat, he's vomiting. Caudal thorax is where I start. Caudal thorax is normal. Okay, the liver is normal, right? Here's the falciform fat, well-fleshed cat, falciform fat, extra abdominal structure. This liver, sometimes if you have a ton of falciform fat, it'll make the liver look small, and then you start talking about microhepatica. But this is a normal liver. Kidney, left kidney, right kidney, summation with the kidney. These kidneys are normal. The urinary bladder is small and fluid opaque. Flip the cat over, make sure he's labeled appropriately, lefty-loosey, righty-tighty. Here's the splenic head, little triangular focus of love. That's totally normal. Okay, then I look at the stomach. Stomach's got a little bit of gas in it. Here's the stomach right here. A little bit of gas, probably a little bit of fluid and some pinpoint mineral. Left lateral view, this pylorus opens. I find that sort of redistribution with cats, comparing pyloric content on left versus right lateral views, it's not as repeatable in my experience as it is with dogs. Okay, so stomach is fairly empty, which is encouraging. Then the next thing you want to do, at least the next thing I do, is I like to make sure the colon, I can identify the colon, because once you identify the colon and you got the stomach, the rest is small intestine, and that's where the juice is. So ascending colon, transverse colon form feces. That kind of helps tell you it's probably fairly acute. Descending colon and rectum are empty. Okay, so that means everything else, there's a wet hair artifact that's just doing nothing but screwing with us. But all these loops right here, there are 3 things that I look at: the size, the course, and the content. And so the size, is everybody the same? Are the 2 populations? Are they empty? Are they mildly distended, etc.? So everybody kind of looks fairly similar. There's certainly not this wide discrepancy between loops. So everybody kind of looks the same. That whole game between, because if you take a small intestinal loop and you pull out all the gas, it'll be soft tissue opaque, right? Or fluid opaque. So it'll look like this loop right here. The game becomes difficult. Is that totally full of fluid and a little bit distended, or is it completely empty, and or does it have a thick wall? So I think that can be tough. But I think these right here have a little bit of gas, a little bit of fluid, and some minerals. And so I think that they are a little bit dilated, all of them. So the size, I think the small intestine is uniform in size and perhaps mildly distended with a combination of fluid and gas and some pinpoint mineral. The course, gentle loops. So you look for the gentleness, but you also want to look for, doesn't always hold in cats, holds damn near all the time in dogs, but you want to see where's the small intestine going in the abdomen. So there's some in the cranial, some in the middle, some in the caudal. So it's just kind of like laying in there. There's some in the left caudal abdomen, the right caudal abdomen, and up here in the center and cranial aspect. So the intestine doesn't have any evidence of plication, which would imply a linear foreign body, or corrugation, which is a nice marker for enteritis. Loops are similar in size, mildly dilated. The contents, size, course, and content. The contents are a little bit abnormal because we've got these mineral foci, and I suspect that some of these are full of fluid. So this person took the rad because they want to make sure that this cat is not obstructed. And in my opinion, the cat is not obstructed. And I think that this would be a great case of, I don't really think you need to repeat the radiographs. It could be a great candidate for follow-up abdominal sonogram should the patient not make a nice recovery following some supportive care. So Amelia's going metal. Amelia, I'd say mineral. That can be hard, right? But I think these are mineral, not metal. I sometimes struggle with that, so don't worry. If they're really small and really robust, then you can worry about metal. But I think this is, this is mineral. We know this is mineral for sure. The internal control is mineral, and that doesn't look so starkly different compared to that. And of course, that's supposed to be your metal marker, your Mitchell marker, your metal marker. And so these are probably mineral. The reason you want to be a little bit careful with the metal is because metal, people start thinking about hemolytic anemias and, left lateral abdomen. So Doc Holmes is talking about left lateral, right lateral, left lateral, sharp gas patterns. This is very tubular, very tubular, very tubular, very tubular. This is a little bit angular up here, but that's probably the colon. Another thing kind of with radiology, because this is a still image at a point in time, you like to see persistence. And so there was a study done from, I think, University of Florida that said you could just use 2 views of the abdomen. You don't need that extra lateral view, but I don't know why you wouldn't take the extra lateral view. But these all, so even if you said, if your eyes convinced you that there were some angular gas patterns on the lateral view, at least maybe you've got the benefit of saying, well, in this VD view, that's very tubular looking and very tubular and very tubular. And maybe that has a little bit of an angular cranial and caudal margin, but for the most part, they're fairly tubular. So I think the course is okay. Any thoughts on the strain? Graham, what's up? Any thoughts on the strange-shaped gas shadows, cranial mid-abdomen, and the coastal arch? Any thoughts on the strange-shaped gas opacities, cranial to mid-abdomen at the coastal arch? Here? If this is what you're talking about, this is fat. Cool. Just covered it. Cool. Yeah. So the one thing that you could wonder is this thing. These kind of bother me from time to time. These little tubular structures that are parallel to the vertebral column and superimposed with the retroperitoneal space. And you want to go, these are ureters. And I guess it could be a ureter. Sometimes you'll watch them go cranial to the kidneys, in which case they can't be the ureter. And so sometimes I'll make some stuff up about fascial planes. I've had some colleagues think they are ureters, although I've seen a normal cat ureter on ultrasound and CT, and they're tiny. So unless that's diseased, in other words, dilated, it's not going to be resolvable. So I don't know. So sometimes I put these in the report and then it's not helpful and people freak out. The kidneys look good. So you can at least say, look, the serosal detail is fine and the kidneys are fine. So it's not this hydroureter or hydronephrosis. And I don't think it persists. It certainly doesn't persist, maybe because you're not catching it. So I don't know. Those things bother me. Hopefully a resident will do a paper and we'll figure out if those are just sort of fascial planes or not, or maybe somebody knows. Okay. 235269. Oh yeah. Ultrasound. Vomiting. Okay, so I'm going to show you the videos, and I'm going to show you the still images, and then I'll just quickly work through the images and tell you what I see. Dr. Holmes, who's a surgeon, a boarded surgeon, thinks it's not a ureter. I don't think it's a ureter either. Okay, here we go. You ready? So this is it's a cat. I think it's a cat. Let me look at these kidneys. Yes, it's a cat. It's a cute vomiting cat. Oh boy. Okay, here we go. All right. So Dr. Allen, I think it's morning in Australia. She's had her coffee or tea and she's ready to jam and she's right. So let me walk you through what I see. Okay. So when you see a sonographer, first thing you want to do is figure out if what they're labeling is actually true. So when you see something that says left adrenal area, that usually means they don't see it. And that also means in this particular case that I don't see it. And so I just say that I don't see it. I'm also not even sure it's the area. The area would usually you'd want to see the aorta. Okay, classic. Normally you see the aorta sort of parallel, and then you see the celiac and the cranial mesenteric arteries just sort of bopping, little two eyes, and I don't even see those. So I don't know if it's even the area. This is the stomach. I think it's severely distended, mostly with fluid, but a small amount of gas and settling debris. The gastric wall is normal. Okay, so this person, the sonographer, has labeled this as small intestine, and that's the first thing you want to do is make sure they're right. And the way that you want to make sure that they're right is, and you want to contrast that with the colon, right? If they're strongly shadowing stuff in the colon, who cares? If it's in the small intestine, we've got a problem. So what you do is you look at the wall layering, and you want the sonographer to be able to give you at least some intestine upstream or downstream to the area of interest, okay? So here you got small intestine. It's definitely the small intestinal layering. You've got the lumen, mucosa, submucosa, muscularis, and some other serosa that surgeons love, but that we can't really see other than this bright line. No, I told you. See this, the damn. Okay. Anyway, so you got the small intestinal layering, right? So you want to see the small intestinal layering, and this is small intestine, and then it leads up to this, which is a strongly shadowing luminal foreign body. Okay, and then it's fluid filled. And then it kind of goes away. Okay, so here it comes. So in real time, it boom pops up. So the thing that Dr. Allen showed too, that the mesentery around here is hyperechoic. So this thing is not happy. Okay, so you've got all of the information that you need to send the cat to surgery, right? You got a shadowing foreign object. You got two populations of small intestine. This one's too big and has a foreign body. And then you'll notice if you look at all the periphery, these are empty over here. There's another big one maybe over there. Can't tell if that's colon, but you got two populations, and that stomach was massive. Okay, the kidneys are normal. I don't see the adrenal glands. I think the cat also has pancreatitis. So in the near field, you look right here. So stomach massively distended, but boom, right here I'm measuring. You can see the pancreatic duct. So there's a little hypoechoic. So I wonder if the cat's got a little bit of pancreatitis. Here's the pyloduodenal junction right here. It pops off stomach, 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 and then boom right there. That's gas, not a foreign body traversing the PDJ. What else? Some other pylorus we don't really care about. Boom, foreign object. Okay, comes up and down. So these sonographers are very good, nicely trained, experienced. They know to show that this is foreign material in the small intestine, because if not, I just call them up and say, you got to prove it to me. Left kidney is normal. Corticomedullary definition, the size is normal, the margin is normal, the retroperitoneal space is normal. Here's the spleen, normal, normal, normal. Stomach, not normal. This is not good. And that would imply that that foreign body is probably fairly upstream. It's not a downstream or a distal obstruction, because this is the pop-off bag. Liver's fine, gall bag is fine. Urinary bladder is fine. There's some pinpoint suspended echoes. Could be lipid. Could be red cells, white cells, crystals. I don't see calculi. They say this is small intestine. I don't know, man. That wall layering is pretty thin. Maybe that's colon. Doesn't matter. Surgical. You could argue, maybe some viewers will argue, that submucosa is a little chunky. So maybe you get a biopsy. Maybe there's some changes from trying to move this foreign object. Maybe he's got underlying inflammatory changes. Who knows? Surgical. This one's too easy. It's a 7-year-old Chihuahua that is dyspneic. 3 views of the chest. Did I already show this one? I already showed this one, I think, last time. Anybody remember this one? Okay, quick summary then. We won't spend too much time. Okay, first of all, technique. Pretty good. Dog's markedly rotated, but he's also trying to die, so you can't fault the team, right? And so you look for these arches, right? These McDonald's arches or whatever, they're tipped off. So he's fairly rotated, markedly rotated, mildly rotated, but not bad, right? Spinous processes, they want to look like sort of dead on midline. He's a little rotated, and you'll see his sternum tipped off here to the side, okay? When you look at the lung pattern, I like the idea of distributions on lung pattern carrying more merit than, say, the alveolar or the unstructured vascular. When you look at this lung pattern, you draw a line through the cardiac silhouette and you just ask yourself, is it worse cranial and ventral or caudal and dorsal? It's both. I mean, there's something down here and there's something up here, but this particular case is worse caudally and dorsally. And it's bilateral, so it's in the right lung and it's in the left lung, but it's worse in the left lung. Put the dog back over on the rotated right lateral view. Same thing. That's not normal lung. And that's not normal lung, but it's worse caudally and dorsally, okay? So when you see a caudal-dorsal lung pattern, sort of in your little algorithm, you should just, once you convince yourself that it's worse caudally and dorsally, it's almost always going to be a cardiogenic or a non-cardiogenic pulmonary edema. You can literally just drop down. We can talk about PTEs and embolic pneumonia and hematogenous pneumonia and toxic pneumonitis from an inhaled toxin. And there can be all these zebras, and you shouldn't forget them. But like 9 times out of 10, I feel like these are non-cardiogenic or cardiogenic pulmonary edema. And then within those, I'm either not seeing non-cardiogenic pulmonary edema cases or they're just less common. And I feel like it's just less common. I think with the incidence of mitral valve disease and all the cute little dogs that we see, I feel like you could probably close your eyes and just say it's heart failure. Okay, so cardiogenic, non-cardiogenic pulmonary edema, you can pretty much start to rule out non-cardiogenic causes through the history, near drowning, electrocution, upper airway, obstructed breathing. This particular case I liked, and I showed it last time, because I don't think that the cardiac silhouette is abnormal. Maybe. So here's your left atrial region, right? So Hopefully, if you can hallucinate. So the trachea or the trachea, for the international folks, comes down here, right? And you got the right cranial lobar bronchus. I mean, you can see that. That's the width of the bronchus. So here's the bronchus, and here's the right caudal lobar bronchus, the left caudal lobar bronchus, and then the cranial. So this is where that left atrium sits. But I don't see a left auricular bulge. Yes, it's probably obscured. But I don't get, maybe there's something here. But boy, the cardiac silhouette waist is not necessarily lost. I mean, a lost waist would come up here and it would go like that. And then a lot of times they do this. So this one is more sort of flamboyant from these pulmonic veins coming in. And this one's rotated, so all bets are off. But the intern goes out in the skull. It's a 5 out of 6 murmur. I did do it, Amelia. The apex. So can you describe the increased opacity at the apex? The increased opacity at the apex of the cardiac silhouette. Yeah, I mean, left lateral view. Okay, so long story short, this is a ruptured cord. Ruptured chordae tendineae. The dog's blown a cord, so it's cardiogenic. So even if you're like, well, I just don't see cardiomegaly, just don't be fooled. It's cardiogenic. Most of them are cardiogenic anyway. But this particular one is cardiogenic pulmonary edema secondary to a ruptured cord. Lucy is talking about this. I wonder if she's talking about this opacity right here. She's talking about an opacity on the left lateral view summating with the superimposed with the cardiac apex. This is a fake out. Okay, so this is actually the cardiac silhouette devoid of overlying lung. Okay, so on this view, in part because he's rotated, but the lung comes all the way down, and that lung is going to contribute some blackness to the image. Okay, this is the ventral margin of the right middle lung lobe. So it's a little bit underinflated. We're not surprised because the diaphragm is pooching forward. It's not pleural fluid because you can see the liver diaphragm margin all the way down here. Okay, so this is fake out pleural fluid, fake out pneumonia. If you look back, you're like, it does. It kind of catches your eye and it's opaque. But it's because this sort of grayness that you see up here is the result of the lung overlying the cardiac silhouette. This area right down here is cardiac silhouette devoid of superimposed lung. The lung pathology would be cranioventral. So cranioventral and not a caudodorsal, Graham. If it's cranioventral and just pretty much cranioventral, it's pneumonia, and then maybe you could talk about pulmonary hemorrhage. I've seen some foreign bodies get down there. It could be atelectasis. Remember, we talked about atelectasis is just absence of gas. And so the lung, when you remove the blackness from the gas and the lung kind of collapses down, it'll have an alveolar pattern. It's just sort of underinflated, but then you have to have that nuance of, is it underinflated, normal inflation? But generally speaking, blood, pus, or fluid. But I feel like 9 times out of 10, it's pneumonia, cranial and ventral. This dog's tachypnic. Okay, good. It's funny. Sometimes I think cases are more straightforward. It's also difficult when different people show up with different levels of experience. I don't want it to be too easy. I don't want it to be too hard. This particular case, this is how I would work through this particular case. So, the first thing that kind of caught my eye was the cardiac silhouette. Okay, so Doc is going with some edema. So there's a dyspneic dog or tachypnic dog. The cardiac silhouette is too big. Okay, so this structure right here is the left atrium. So that's the caudal margin of the left atrium, and it kind of comes down like that, okay? And then on this view, it's hard on this view because there's pulmonary disease, but this is the left atrium right here. So, okay, you don't know that's the left atrium there, but I feel like it's a little bit easier to see that that's the left atrium. On the VD view, now if you zoom out, just to kind of show you, like this is the caudal margin. So this whole structure right here is the left atrium, right? Because as the beam comes flying through the patient, it just hits more tissue because this left atrium is enlarged because of eccentric hypertrophy, and it attenuates or lessens more of the beam that hits the detector on the table. So it's just more opaque. And then this is a 2 to 3 o'clock left auricular bulge. 12 to 1, 1 to 2. 1 to 2 is usually your MPA. 2 to 3 is your left auricle. It's a little too round. So I would say this is moderate, predominantly left-sided cardiomegaly. The next thing to decide is, does the dog have a lung pattern? Now, this patient is expiratory because this diaphragm is overriding the cardiac silhouette. But if you drop this down, you go, oh yeah, there's just a ton of funk back here, and there's nothing really up there. So maybe we've got something here. Okay, maybe, but he's expiratory. If he's expiratory, you're going to be losing a little bit of gas. So you can be fooled to thinking that there's something there. But when you flip the dog over and you compare left to right, there's too much. Right here is where my eye goes. So when you look at this opacity compared to that opacity, and you can zoom out, there's a little bit too much there. So then you go, there's moderate, predominantly left-sided cardiomegaly. On the lateral views, I'm worried about a caudal dorsal lung pattern. I confirm that there's at least something going on in the right caudal lung lobe. Okay, so the lung pattern localizes caudally and dorsally. I got a bulge, and it's bulging. So I'm going that this is left-sided congestive heart failure. The next thing you do is you look at the trachea, and it's got a normal luminal diameter. And then right through here is where the principal bronchi and the carina are. And I don't see that there may be, it's tough to decide or to know for sure whether this left atrium is sort of punching up on the, well, it is, but how much is it actually compressing or narrowing the bronchi versus this is the ventral margin of the esophagus and this is the dorsal margin of the esophagus. That's probably that dip right there is with the azygos vein. But you may have a little bit of, it's hard to tell because you've got lung pattern, you've got esophagus, you've got left atrial tissue. And so you could say maybe there's some narrowing here. It's not collapsed, but maybe there's some narrowing. The esophagus is tough. We wouldn't be surprised that the dog would have aerophagia because he's presented with a dyspnea, tachypnea, and he's got some heart disease with failure. This is probably food. So that's what I got. Heart failure. If you were concerned that there was something here on the lateral view, or if you're like, damn it, this dog has heart failure based on the way he's presenting in the physical exam and such, and I just don't see it, the DV view is ideal. So this is a VD view. The DV view gives you the best opportunity to put gas in these lung lobes caudally. So the gas, which is black, which is what we want to contrast with the opacity of heart failure of the fluid, gas comes in and it's better aerated in the caudal lung lobe, so you have a better chance of seeing low-grade, especially low-grade edema. UC Davis does 4 views of the chest. I don't think that's a bad idea because sometimes I'll get these cases where I think there's something there. A lot of times they take these cases because they go, does the dog have heart failure or not? And then I send a report back and I'm like, I think. And if it's low grade, this isn't low grade. This is classic or pretty clear heart failure. But if it's low grade, that DV view can really make all the difference. Nodular pattern caudal to the heart. I think the blood vessels right here. Here. That's a blood vessel. Anytime I see, there's Dr. Elaine's probably talking about this one. This one's got a rat tail hanging off of it, so it's tubular, and so that can't be a met. Anytime I see some of these nodules and they're up near the hilum, which this is getting there, it's certainly not down here around the periphery, and the animal's got cardiac disease, and he's in failure, and there's venous congestion. The pressures are just too much. That's got to be, I think, let's not ruin the owner's weekend completely by saying that he's got, cardiac disease and Mets. It's possible, but I would venture to bet those are more likely a collection of dilated blood vessels. Yeah. So the vessels, the number of times where I feel like, and I don't know if it's because we predominantly read for specialty clinics, and so these dogs are on diuretics or they've had heart failure before, and so intermittent heart failure with medical therapy results in sort of wonky, changes to the blood vessels. But I feel a lot of times I'm saying that this dog is in heart failure and the pulmonary blood vessels in the description are normal. This one's probably a little too chunky. Trachea, cranial lung lobe, that the pulmonary vein to that cranial subsegment is normal. That one may be kind of big, but they're not anything to get excited about. But it's heart failure. You're not tired. I just didn't explain it well. I think the esophagus is, I don't know, but if I had to guess, I would say that's aerophagia. we've got some explanations for aerophagia, and the dog's got a belly full of recently ingested food. So it's possible, and I think more plausible, that the dog has aerophagia. The other thing that I know that megaesophagus it's a term that I would only use. I feel like if you say megaesophagus to somebody, they think Bailey chair and recurrent aspiration pneumonia and nightmare. So I won't use megaesophagus unless I'm fairly concerned that there's a motility disorder, like an idiopathic megaesophagus or a myasthenia gravis, because it's a very sort of inflammatory term. So I'll just say, like, the esophagus has moderate segmental gas distension, and then I'll talk about how I think this is aerophagia, because we've got a lot of reasons to suspect aerophagia. It's possible that it represents a motility disorder, such as causes of megaesophagus, like Addison's disease and polyneuritis, polyneuropathy, polymyositis, brainstem injury, idiopathic myasthenia gravis. Am I missing anything? Yeah. So I think that dog had a gas-filled esophagus from aerophagia, and the report probably wouldn't have said megaesophagus. This dog's vomiting. I don't know if I see both dilated and small vessels and uneven distribution commonly. I don't know. I feel like I don't know. Let me think about that. I think it's there have been instances where, I mean, you can watch it on fluoro, but there have been instances where I'll receive radiographs where they're taken in very quick succession, like back to back. It's like they double, almost like a double acquisition. And at least I've been surprised by the hemodynamic differences that can occur so quickly and that are so noticeable radiographically as it relates to the heart. Like, the heart looked abnormal, then the heart looks normal. And so I guess I wouldn't be surprised with the blood vessels changing size due to differences in sort of temporal pressure, plus or minus their own diuretics. So I don't know if that's a useful answer, but I think for me, I mean, I think for me with the vessels, I think the vessels are sort of like added support. You know, I think if you've got the cardiac silhouette and the caudodorsal lung pattern, if we've got the vessels, it's like the slam dunk. If we don't have the vessels, it's like, I don't care. Okay, dilated colon, stomach empty. No, it's yeah. Okay, yeah. Gastroenterocolitis, right? So caudal thorax. Let's see, caudal thorax is fine. He's got these vertebral body anomalies, which means he's probably a brachycephalic. Even though the positioning's not good because these ilial wings are tipped off and the hip joints are tipped off, so the dog's probably rotated a little bit, which will contribute to the impression of narrowing. My guess is some of these are probably pathologically narrowed. I thought. Yeah, colon, gas, a little bit of fluid. There's the cecum. Stomach right here, a little bit of fluid, a little bit of gas. The rest is small intestine. The size, everybody looks fairly similar. Where is it? Yeah, size. The course, I don't see any plication. The content, everything's mostly with gas. Maybe there's a little bit of fluid or Wolfe hanging, but it's mostly gas. Intestines pushed cranially. Pushed, or they just have, you know, the urinary bladder, where was it on this one? It was sort of right here, so it's moderately distended. I don't know if they're pushed cranially. I think the liver is kind of on the skimpy side. The stomach is pushed forward, so I just think they have room to move cranially. But it doesn't bother me because there's no suggestion that they're entrapped or something, as I don't have a two population. The other thing that's interesting is usually if there's pancreatitis, one of the things that you could envision is that the intestines move away from that area because of the inflamed fat. And so I think one of the things that's it's certainly not some sort of rule, but you go, well, these are kind of up in the cranial abdomen. And so even if you thought, well, maybe the dorsal detail is reduced, I think it would be interesting for dogs with pancreatitis to have intestine right next to it that weren't corrugated. I think that's it on this case. The hip joints. So you may look at these hip joints and you go, well, this one's got reduced coverage. Not that this is like fat shaming or body shaming, but one of the things that you can use as sort of a way to remember is this ilial wing is thin. and thin is in. And so when you have a thin wing relative to this wing, so this wing is not as thin, it's a little bit thicker because it's sort of filleted out, and this is thin. Thin is in. So this one will look like it artificially has more coverage, and this one subsequently will look like it has artificially less coverage. So you can also look at the obturator foramen, but that's a rotated pelvis, so not a big deal. Okay, I think that's it. We made it to an hour. I still have another hour of work. Got some cases, some stats, some people calling me. I don't know. Email me or let me know if there's any particular cases that you want. It's hard to know who's gonna return and who's new. I could start going bonkers on musculoskeletal, throw in some more ultrasounds. Let me know. But thanks for showing up, and I hope you guys have a slow and steady week. Okay, bye.